You can go into more elaborate detail if you need about the downfalls that we have seen in society with the use of significant narcotics, so that, most family members are very concerned. They don't want their family members taking narcotics. And I think that generally they're thrilled that someone's taking the time to educate them and to provide an alternative.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
On this week's episode of First Case, we are speaking with our own podcast celebrity at this point, Dr. Michael Redler. He is joining us for a third time on the show. And Dr. Redler is an orthopedic surgeon. He is an advocate for opioid-sparing techniques. And he's also a very dear friend of mine. And we are going to talk about our connection, talk about our time in Honduras serving together on a mission trip. But we're also going to talk about his approach to opioid-sparing techniques and how he treats his patients holistically. And it's going to be an incredible interview.
Well, and I can't wait for the mindset shift that's going to occur. And last but not least, Tylenol. If you're listening, we've got a star in the making.
We absolutely do. Do not go anywhere. We will be right back with Dr. Michael Redler.
Hi, I'm Chris Blevins.
And I'm Melanie Perry.
From the studios of Healthcare HQ, you're listening to First Case.
Joining us now is Dr. Michael Redler, and Dr. Redler is an orthopedic surgeon and also a very dear friend of mine and someone who is coming back for the hat trick of interviews on First Case. So, Dr. Redler, thank you for coming back to talk to us again.
Melanie, it's thrilling to be here with you again. And, not being much of a hockey player, though I can skate, this is probably my only opportunity for a hat trick. So I'm pretty thrilled to be able to call that an accomplishment completed.
Absolutely. I'm glad we could, help you achieve that accomplishment. And the first time you were on the show, we talked to you about your mission work in Honduras, which also led me to join you in Honduras. And I've referenced that trip several times during the season. Also, we talked to you about communication in the OR and how important that is and how it can affect patient care. But today, we're going to be talking about opioid-sparing techniques in orthopedic surgery. But before we go into that, I know we have new listeners who don't know who you are yet. So why don't you just take a minute and introduce yourself to everyone?
Well, Melanie, that's a pretty darn good introduction. I'm Michael Redler. I'm an orthopedic surgeon. I specialize in sports medicine, upper extremity surgery. I'm a partner with Connecticut Orthopedics, which is now the largest orthopedic group in New England. In addition to functioning as an orthopedic surgeon, I do like to do a lot of teaching. I've got an academic appointment with the Frank H. Netter School of Medicine with Quinnipiac University as an assistant professor, and still have a visiting assistant clinical professor of orthopedics at University of Virginia. Those are my titles. My passions, well, you've already talked about one of them, is medical mission work. And frankly, my other passion is opioid-sparing strategy. So you're spot on in terms of asking me to come back tonight.
Well, actually, to be honest, because we had already talked to you twice, I kind of felt a little, should I ask him to come be a guest again? I know he talks about and is passionate about opioid sparing surgery, but maybe he doesn't want to be a guest on the show. And then you were like, this is my specialty. I'm like, I know, you're right. So why don't we talk to you again?
Well, and as somebody who listened to your past interviews, I was really excited to get the chance to actually interact with you for this one. So thank you for giving me the opportunity to get to be a part of it and for coming back for a third time.
Well, I appreciate it. And, Melanie, I love talking to you. And Chris, I'm pretty certain I'm going to love talking to you as well. And by the way, I probably can have hashtag hat trick after tonight.
So, Dr. Redler, we heard that you almost missed your calling as an actor to add to all of these accomplishments that you've had. But Tylenol, unfortunately, is going to miss out on having your incredible skills in an upcoming commercial.
Chris, you obviously have done your homework, and it's very impressive. For many years, one of your previous guests, Scott Sigmund, and I have done a lot of lecturing about opioid-sparing strategy. He calls himself the original opioid-sparing surgeon. And the reality is that is true. I probably joined the bandwagon shortly after that, but nevertheless, I feel I was right at the forefront of that as well. Most recently, Scott has some medical issues that were going to prevent him from fulfilling some of his responsibilities. One of them is he got asked to do a Tylenol commercial. So one day, I get a text from him and said, "Hey, check your email."
That's always exciting.
Yeah, so I checked my email, and essentially he connected that he apologized to the Tylenol people that he couldn't do the commercial. However, he had the perfect person to substitute for him, and he had asked me to do it. And I, felt honored, but at the same time concerned about his well-being, said that, listen, I'm happy to help out. I think that we can do a great job. We can do something that will make Dr. Sigmund very proud. Well, P.S. fast forward, his medical issues became much less of an issue or handled in a much simpler fashion. And when he let me know that he wasn't going to have a major procedure done, he said, he was so thrilled. I said, "I'm so happy for you. I'm so happy that you're going to be well and that you do great." And he goes, "Oh, wait. What about the Tylenol commercial?"
I can't at all take credit for, Dr. Sigmund ratted you out. Like, that's just,
Yeah, so he said, he sent me a wonderful text. Dr. Redler, today was a wonderful day. I found out that I wasn't going to have to do a major medical procedure. But on the other hand, for you, it was kind of like a Larry David episode. You had a Tylenol commercial, and then lo and behold, it got taken away from you.
It got taken away from you.
So I'm pretty certain I need some T-shirt saying, "Hi, Dr. Michael Redler. I almost did a Tylenol commercial."
Well, if anyone from Tylenol is hearing this episode, here's part 2.
Exactly.
So, it's just another opportunity.
I will tell you that, and doing the little bit of the connection there, for all of my patients after surgery, one of the preliminary things they do in terms of our opioid sparing strategy is they all will take 2 extra Tylenol 3 times a day by the clock, not based on symptoms. And we do that as part of our multimodal approach to minimize opioid use. So there is a direct connection. I just don't have the commercial.
Yes.
But you don't have the commercial yet. But the connection is good because that's what we are talking about and discussing in this season is how surgeons, how as healthcare providers, we are preventing opioid abuse, opioid addiction by using these opioid sparing techniques. And one thing I'm actually curious about, also talking about Dr. Sigmund before we move away from him and go into the rest of this interview. In his interview, he talked about the traditional ways that surgeons were trained regarding the use of opioid medications. And I'm curious if your experience in your training was similar to his in what you were taught about the use of opioids.
We were taught very clearly that if you weren't handling the patient's pain, you were not taking good care of them. And part of handling the patient's pain included opioids and being sensitive to that. And there are two parts to that whole theory. Certainly handling the patient's pain, or frankly, I almost never use the word pain, by the way. When I talk about patients, we talk about, how we're going to handle discomfort. The meaning is the same, but the inference and what the patient hears is completely different. So we were taught that, and we were told, we would be, ostracized if we were not handling that. What we've come to learn now through the years of where all of that came from, and it was from the pharmaceutical industry, it was from Purdue, it was from the Sackler family, and what we've had to do is be salmon swimming upstream. And long before this became a popular topic, I would tell my patients who were asking, say, hey, I need a refill of medication. I said, listen, good, well-meaning people get addicted to pain medicine. It's not some bum in the street. It's not some addict. And what I would tell them, if I were not having this conversation with you, I would be doing a disservice to you. And that was well before this became a very, very notable and, publicized issue there.
Well, and it's obviously you're very concerned about the mindset of your patient and, making sure that you differentiate between discomfort and pain and how that frames what their experience is. I also want to know what your experience was and what caused you to become an advocate against opioid use and for opioid-sparing techniques in your current practice.
Chris, that's a great question. And I think in my gut, long before it became a popular issue, I just knew it was wrong. And look, any of us as clinicians will know the side effects you see from opioids. You see the nausea, you see the vomiting, you see the psychological as well as the physical dependence. And these are people who didn't necessarily mean to. And then beyond that, you start seeing around the community with, patients dying of overdoses, kids dying from overdoses. And it becomes crystal clear very, very quickly that this is not an answer. And I think I knew it early on, and you saw the bad effects from it, and you knew there had to be a different alternative. And in the first alternative I was doing, that was just talking to the patient and patient education. We now know with all the advances that have taken place in terms of multimodal therapy, in terms of effective blocks, in terms of long-acting local anesthetics, there are so many ways that we can handle patients' discomfort. And that's right, I did not use the P word.
I need to change my vocabulary because it is true. We were taught that in nursing school too. It's a word difference that, and it can make a huge difference in the patient's perception. And I'm curious because you actually already hinted at it. You talked about how you use Tylenol around the clock with your patients, but I want to know what your approach is with your patients. Like, walk us through from before surgery, when you educate them, all the way to when they have a follow-up. What are you doing with your patients to manage their discomfort?
Yeah, and that's so important. And the first thing is you talk to the patient. And we talk, if we're in the office and we're talking about having surgery, we're going to take them through every step of the venture. Maybe you need to get medical clearance. We're going to do this as an outpatient. This is what we're going to do. And then we talk about how we're going to manage discomfort. And we talk about, for a lot of patients, they can have regional blocks. For a lot of patients, they can have long-acting local anesthetics. But I will tell everyone, what we're going to do is we're going to use a multimodal approach for discomfort. And that's going to perhaps include a nerve block. And we have fabulous anesthesiologists that we work with. It's going to include extra-strength Tylenol regularly. It may include either an ibuprofen or a meloxicam as an anti-inflammatory medication. And if we prescribe a very small amount of pain pills, I said and we say pain pills. So pain pills for me would be solely the basic 5 milligram of oxycodone. And a patient may get 5 for a rotator cuff or for an ACL reconstruction, what we tell patients is this is not for regular use. It's just for breakthrough pain. And we do this as part of our opioid-sparing strategy. And the good news, it works great.
And are the regional block? Oh, good. Did you want to keep talking?
Well, did you want to keep talking? There is a microphone in front of you, Redler. You probably will. Well,
I didn't want to interrupt if you were going to keep going.
No, well, the only thing I was going to say, I have that conversation with them in the office. I have that conversation again with them in the preoperative area. And I have that conversation again with them in the PACU, in the post-op area afterwards. So they've now heard it 3 times, and it really sinks in, and they become part of the team to make this opioid-sparing strategy a reality.
Yeah, they hear it time and time again. They understand it, and they incorporate it into their own care. And I'm curious too, you mentioned regional blocks, and we've had discussions about regional anesthesia throughout this season. Because your patients are getting regional anesthesia, they're getting blocks prior to their procedure. When they come back to see you post-operatively, were they always needing the narcotics that they were prescribed, or were the blocks doing their job and taking care of that discomfort?
Yeah, I think the overall approach has done its job. So the level that we have now accomplished in terms of regional blocks and long-acting local anesthetic has been fantastic. And I have patients who've had ACL reconstructions with meniscal repairs and, these college baseball players who never took an opioid. They took Tylenol and some Advil or some meloxicam. And I think it's an overall success, but it's based on a team approach. You have to have skilled anesthesiologists. You have to have the patient education. You have to have them buying into it as well. And all that together has created great success where we use minimal or no opioids, and we can do so. But great regional blocks that are effective and long lasting are part of that overall algorithm.
I would also think that you have to educate the family members for what to expect as well. There's a lot of anxiety that goes into not only the patient having to go through these procedures, but the family and how to care for them appropriately. And so how do you alleviate the anxiety for the caregiver to the patient, knowing that, there's not this preconceived,
Yes. So Chris, the good news is in the pre-op area, there's always a family member with them. They're hearing the speech. They're hearing the speech again at the PACU area afterwards. So they've heard it at least twice. The patient themselves have heard it 3 times every single time. And some of them will go, yeah, okay, Redler, we heard your spiel. On to the next thing.
We know the drill. Let's go.
Yeah.
But I think that the reality is that you get them to be part of that overall team. And we talk about the importance, for instance, with taking with the Tylenol, for instance, that's not based on symptoms. You just do it based on the clock. And so you get them to buy into that as well. And, look, you can go into more elaborate detail if you need about the downfalls that we have seen in society with the use of significant narcotics, so that, most family members are very concerned. They don't want their family members taking narcotics. And I think that generally they're thrilled that someone's taking the time to educate them and to provide an alternative.
So I want to shift the conversation just slightly to blend your 2 passions, which are the mission work you do in Honduras and opioid-sparing surgery, because I saw everything that you've talked about so far. I saw it in person when we were in Honduras. I saw these patients come through the clinic. They were seen in pre-op. They got their blocks prior to surgery. We rolled them into the OR, and we actually got to see them because we were so close in the PACU and then in phase 2, and they were being discharged, Tylenol and ibuprofen. And I want to hear you talk about the patients that we treated there and just the process of their care and what they experienced.
Well, it's interesting, as you got to see firsthand, that working with One World Surgery and in Honduras essentially helped to confirm a lot of what we thought in terms of being able to minimize or eliminate opioids. And some people will say, well, gee, the Honduran people, they're tough And they are. And they're tough, but at the same time, they're very grateful. But in addition to that, what it showed us is that with appropriate minimally invasive surgery, with use of long-acting local anesthetics, and with non-narcotic pain medicine, that you can do major surgery and have these patients go home and be eternally grateful. And it sort of confirmed what we had thought. Now, interestingly, one of the long-acting local anesthetics that we use is Exparel, which is from Pacira. And we were fortunate enough, thanks to Pacira, to early on be able to take Exparel down to Honduras with us. And Melanie, the mission that you or I on, we used Exparel as well.
Yes, we did.
And what we learned long before there was even an indication in this country for using it for lower extremity blocks, that if you were using it for an ACL reconstruction with an adductor block and then for local infiltration, these patients could be completely comfortable. So not only did it confirm that the opioid-sparing strategy was going to be effective, but it gave us an opportunity to confirm that some of these strategies were going to work extremely well.
That's incredible. And I was just blown away as I was there, seeing these patients when they were in recovery, getting ready to go home. And I talked to a few of them, and their pain was zero. And we were speaking in Spanish. I mean, they were communicating, not just agreeing with me because I was speaking English and they just said yes, but they, they weren't hurting and they were going home without pain. Their blocks were working. And there's someone at the clinic, even when we're gone, for them to have follow-up care and for them to, be seen later, or maybe if there's an issue. But these patients aren't calling later and saying they're in pain and they need narcotics, right? I mean, their pain is managed at home effectively with their Tylenol, correct?
That's correct. And I would argue that if they couldn't understand you, it may not have been the Spanish, it may have been the Alabama accent, but nevertheless.
I'm a little Southern, I know.
No,
but
we Southerners around here.
We love it, but that may have been part of the issue. No, I mean, I think it confirms it. And as you know, we do big surgeries down there.
Yeah, we did.
We do big surgeries down there for patients that have waited a long time for it there as well. And look, there may be some cultural differences. I think we need to recognize that. But having said that, people are still people. And we know there's a better way. And this has helped to confirm it for us.
I've heard so much about the great work that you and the rest of the team did in Honduras. And I've also seen what advocates you guys are for opioid-sparing surgery. And I wonder, I know you educate your patients and their family members about the importance of these, liposomal bupivacaine and all these other alternative care. But how have you used your platform and your passion to educate other surgeons or other healthcare providers to follow the same path? Is it a difficult path to kind of make them follow you on?
Well, I think it is much less difficult now than it was 10 or 15 years ago, when we truly were salmon swimming upstream. And I think that what we have done is in many different venues, Melanie, including the AORN national meeting when it was down in New Orleans, we did a panel on that. We've spoken to many different segments of the population. And then you speak to smaller groups and you ask a basic question. If you're doing a knee arthroscopy, how many opioids do you prescribe? And hands go, 30. 30?
Wow.
Right. Why would you need 30?
Wow. Why?
Well, exactly. I mean, it's shocking now, but that was sort of the standard. Why do you prescribe? Well, I don't want my patient to be in pain. And I frankly don't want a call if they need a refill. Those are two very common ones as well. And I don't want to seem as though I'm not caring. Well, fast forward, and we're now in 2024. We know caring is having that conversation with the patient, looking for alternatives as well. If you manage it well, you're not going to get those calls. But the bottom line is, if our most important goal is great care of the patients, that's great care of the whole patient, not just the broken part. And we talk about that a lot. And if great care of the whole patient means that they are not going to get exposed for the potential of opioid addiction, or their families or members are not, because of those days gone by when there were 30 Vicodin or whatever prescribed for a knee arthroscopy, patient probably took a few. You know where the rest of them were sitting? In the medicine cabinet. And if it's in the medicine cabinet, it may not be the patient getting it. Maybe it's the patient's 17-year-old son. Maybe it gets distributed in the neighborhood. The bottom line is that we know that a lot of what we're doing is not just for the patient, but for society as a whole. Because an awful lot of the overdose that you see, an awful lot of the addiction you see, probably started with prescription pain medication. And it's not just the patient. It's the patient's family. It's the patient's greater circle. It's the patient's village. So in fact, when we're doing all of this to minimize opioid use, we're not just protecting the patient. We're trying to protect society as a whole.
Yeah, I know. I have to admit, I've got an old prescription of pain medicine in my medicine cabinet right now. I mean, it's kind of natural tendency. You get the prescription, you don't use it all, you tuck it away in case something hurts later so that you'll have it, and then you forget about it.
Right,
and
exactly.
I actually was sharing before we started recording, but I had a very, very negative experience last year with a family member who was having a mental health crisis. And one of our requirements was to go through the house and look for any narcotics that we had and hide them so that we could protect her from herself. And then I'm going through it. I'm like, holy smokes, I have some stuff tucked away.
Yeah.
And you forget about it. And because you forget about it, somebody else can find it. And then the ramifications of that can be huge.
Yeah, it's a scary situation. And if you have not read it, I will recommend strongly a book that I occasionally quote when I speak about this. Is called, the name of the title of the book is Empire of Pain. And Empire of Pain originally starts about the Sackler family and how some of the original Sackler docs were not only physicians, but also owned an ad agency, and how they promoted it, how they influenced the DEA to get some of these things passed. They ultimately were the founders of Purdue Pharma. And it's a fascinating book about how it was all built up to want to prescribe more and more. And they were actually also the people who created OxyContin, which was the long-acting pain medicine. And by the way, they also pushed out all these studies about the fact, well, the good news is really not addictive, which we obviously know is false. So there is so much that's built up to the point whereby, having pain medicine in that cabinet was more the rule rather than the exception.
Okay, so I have to ask, because I love a good book like that when it uncovers so much information. But was there a connection between these people in this book and their influence on pain and medication, and also this idea that pain needed to be a vital sign and that we needed to measure like HCAP scores,
yes,
including
absolutely.
pain?
Absolutely, to the point whereby they probably promoted and probably came up just like you would do any other advertisement. Pain is the fifth vital sign.
Absolutely.
That's from them.
Dynamic measurement is that.
So it is a scary book. And again, it was a bunch of people fighting upstream to try and overcome this as well. And their money and their power helped to divert a lot of the punishment that perhaps should have occurred. But it's really an eye-opening book talking about, getting right back to the point when you had, how heroin came around. It was thought to be something that would be the cure, so you wouldn't be addicted to morphine.
I remember that.
Yeah. And
trade
then
one bad
ultimately
habit for another.
Oxycodone. Well, if you took OxyContin and it lasted 12 hours, you wouldn't have that break. It was a tremendous ad agency. You see the companies now paying $7 million for 30 seconds of a Super Bowl commercial. This was the original ad campaign that helped lead us down this primrose path.
And I think there are movies, there's books, there's a lot of articles on the opioid epidemic and how that started and was proliferated. And it is mind boggling because I think you can get kind of naive and maybe blinders on thinking that medicine is just about helping people. And those of us who have been in it for a while, we can be a little jaded, but to see how deep it went was kind of terrifying. And that's where I want to leave you, not the terrifying part. But, but for those of us who may be a little terrified, but have hope through what you and your colleagues are doing, what are your final thoughts that we should take away with this incredible season that has been really educational? But are we missing something? Is there something that we should circle back to?
I think we are headed in the right direction. But to assume that we have finished the goal and gotten to the end line, at the end zone, is not correct. And I think we've touched on some great points. And one of them we talked about is the education. The second is our whole mindset of how we think about pain. And one of the things I've said in a lot of lectures, and I'll go right back to the beginning, is that, when you're a patient and you come into the surgical center, you come to the hospital and you're about to have surgery, what's one of the first things you do preoperatively? You show them that piece of paper with the smiley face, with the frown face. And
how would you rate your pain?
How would you rate your pain? Exactly. Mm-hmm. We're saying it wrong. And if there's a take-home message from this as well, we need to eliminate the concept of a pain scale. What we need to do is create that same, it can be the same paper. It's the comfort scale.
I like that.
Don't tell us how this is a little, and you can have the same silly faces. Let us know what your level of comfort is. We've changed one word and we've changed the whole paradigm. We've changed the whole concept there as well. And what we should be striving for is not pain reliever. We should be striving for comfort. And the way you do comfort these days, you can use an Exparil. You can use a Zen Relief. You can do regional blocks. You do a multimodal approach with Tylenol. Yes, I still didn't get the commercial.
Yes, Dr. Redler.
With anti-inflammatory medication and with patient education. And we can get patients well along the way to that comfort scale. And the good news is there's more coming down the pipe. And we've been working a little bit with a company now called Gate Science. And Gate Science is trying to bridge what's called the efficacy gap. And the efficacy gap suggests if you even do a long-acting local anesthetic with your nerve block, if it's a short-acting, it'll last 18 to 24 hours. If it is long-acting, maybe it'll last 3 days. But there may be some residual discomfort. Notice I still didn't use the P word. And so what Gate Science is doing is creating a single injection catheter with a small little electrode on it that gets controlled by your iPhone. And when that block starts to wear off, they go to neuromodulation. And neuromodulation overwhelms the pain fibers. And patients will ultimately be able to control it on their iPhone. Because the efficacy gap is something between that 72 hours and when they're resuming more regular activity. And so you can have a relatively pain-free, I did use the P word there, but for up to 30 days. So that's going to the next stage along the way. And this is in clinical trials now. It is very exciting. It's going to be the next great thing to bridge that efficacy gap. And that's where we're headed. So we're not finished with the job. We're on the right pathway, but we need to get to the point where everybody gets a great score on the comfort scale.
That's amazing. I have nothing to add. Thank you so much, Dr. Redler, for joining us again. It's always a pleasure to have you on the show.
Well, Chris, Melanie, it was terrific to be with you guys. Never be shy to ask. And, I'm sorry that you couldn't get a Tylenol star on the show, but
we are not sorry at all.
I am a big advocate. And this is, I think, one of the most important things that we're doing, as I said, not only for patients, but for society as a whole.
That was Dr. Michael Redler, orthopedic surgeon at Connecticut Orthopedics and an opioid-sparing advocate. And Chris, it's just so awesome to have somebody want to come back on the podcast and talk to us again after we've talked to them twice already. But Dr. Redler is such an advocate and a champion for orthopedic sparing modalities. And what I really loved was his emphasis on the paradigm shift of the words that we use. Discomfort instead of pain, managing your comfort level and not your pain level. It seems small, but it's really huge.
It's really big. And every time we talk to someone about this topic and every other topic, like I learned so much, but also you just learn their passion, not just for their particular genre of surgery, but for their whole patient. And what he said time and time again about the decisions that we make are affecting society. It just goes to show you how lucky we are to have caregivers like that. And I'm just so grateful that he was on the podcast.
Yeah. To have caregivers who see us holistically and not just as a diagnosis or just a ACL repair or a rotator cuff repair, but there's more to us than that. And to treat us holistically makes a huge difference in the care that we receive and the outcomes that we have. That is going to do it for this week's episode. On behalf of Chris, myself, and the whole team here at First Case, thanks for listening to this week's episode.
Thank you for listening to this week's episode of First Case. As a reminder, you can help support us by subscribing to First Case on your favorite podcast app or by downloading the smartphone app on iPhone or Android. Simply search for First Case in the App Store or Google Play. The best thing about downloading the smartphone app is that you can access bonus content for certain episodes and view episodes in certain categories, like articles on the go and vendor spotlights. Are you following us on LinkedIn or Facebook yet? If you are and you love an episode or post, then let your social network know about it. Like, comment, or share our posts along with your thoughts and keep the conversation going. If you have any topics or guests that you would like to recommend for a future episode, just send us an email to info@firstcasemedia.com. We look forward to hearing from you.